Now, there could be apples and oranges, there could be overlaps, you could have variegated patterns. So, it's all up for grabs as far as understanding the disease better. So, here's a classical case 20-year-old gentleman, uh, fasting hyperglycemia, grossly underweight from our rural area, about 10 kilometers from our medical college campus. Weight loss. Important thing is the birth weight over here, which we got. Nowadays, when I sit in my outpatient, I always ask my young people who have diabetes, what is your birth weight? And of course, most young men don't know their birth weight. So I'll say, please call your mother and find out the birth weight. So it's a pretty useful tool which you can employ as well. Despite that, of course, from rural areas, many of them will not know their birth weight. But if you do know it, it's useful. Their BMI was low and no other clinical findings. This is the lipid profile, as you can see over here, and glucose levels of 12.6 A1C. We controlled the glucose of the next 6 months before we did the clamp studies. The patient gained 1.5 kilograms over the next few months. We've ruled out malabsorption. The elastase levels were normal, and that's after correcting the glucose for 6 months. We found the C-peptides were low in the fasting state, and postprandially, C-peptides showed a mild surge. There's no evidence of fatty liver on the ultrasound. Again, the DEXA done after 6 months showed percentage body fat of 17.4, which is very low. So, the genetic analysis, this is not mandated, but this is part of our research study. A 62 gene panel was negative. So, lean, young onset, non-autoimmune, fasting insulinopenia, normal pancreatic structure, low total body fat, non-ketotic, no hereditary pattern, qualifies for type 5, controlled with sulfonylureas 3 mg per day. So what is the pattern? Of our series of lean diabetes patients, 50% do not need insulin. And that is the good news, that many of them could be controlled with oral anti-diabetic agents. Now, I was asked this question as to why or how. What is the mechanism they work? It's like, is there some epigenetic change in the beta cell membrane which is enabling them to respond to other oral anti-diabetic agents? We don't know the answer to that question. We only know the good news is when you give them OADs, they can stay very well controlled. They have a sense of well-being, and they never develop ketoacidosis as well. And they put on small amounts of weight. We have had a follow-up now over 6 years to 7 years of some of these patients. Despite reasonably good calorie intake, their weight gain may be at max 3 to 4 kilograms. So they don't become obese. So insulin therapy in 50%, OADs. We know metformin works through various mechanisms. Even though these patients are lean, low dose metformin we think is an option, and they don't seem to lose weight. So, but this is all up for further research. High protein diet, we do believe, will stimulate beta cell function. We know that certain essential amino acids, arginine, isoleucine, can actually stimulate insulin production. Will it cause partial reversal? Who knows? And we talked about resistance exercise and aerobics, improving glucose transport. Once again, therapeutics is an area which really needs to be researched in detail. So we need to relook at the diagnostic criteria, and we are in the process of actually doing epidemiological work, like how you have Jones criteria for rheumatic fever or for criteria for diagnosing Marfan syndrome. We need to figure out what are major and minor criteria. But the spread of common factors, I'm not saying we need to have everything in everyone, but the essential things is ruling out. Therefore, C-peptides, GAD antibodies, and imaging of the pancreas is mandated. These tests have to be done. Beyond that, you have to kind of match and mix your other findings to try and make a diet. But we are not on solid ground to make diagnostic criteria. Now, if someone can tell me what the diagnostic criteria for diagnosing type 2 diabetes is, you'll get a gold medal for that. Maybe a couple of the endocrinologists in the front can tell me as well. So that was that. And this is how we investigate, what I already talked about. And the mandated tests, which we definitely need to do in these patients. So one of the arguments is could this be SIDD? You know that type 2 diabetes, according to a Swedish group about a decade back, has been divided into 5 clusters. So you have this group called SIDD, so-called severe insulin deficient diabetes. Now, they do have lower C-peptides, but they're not grossly C-peptide insufficient. And I don't like the name severe insulin deficient diabetes, but anyway, that's the name that it's been given. Nor is it AD or WHO classified or anything of that sort, but it's a good concept to divide type 2 into various forms, more insulin resistant, less insulin resistant, etc. So we looked at some of the data. This is the study from Mohan showing the SIDD cluster, their median BMI is 24.9. So there are some of them, if you look at the standard deviation, who have a very low BMI, but they are not extremely lean like our patients. And their C-peptides, they didn't actually have routine C-peptides done in these patients. So, and this group had C-peptides. So you can see the C-peptide measurement at the bottom of 0.8. They're lower, but the BMIs are on the higher side. This is again another study which was, kind of pan-India, involving many people from across the country. Once again, you look at the trend is that the BMIs are not that low in SIDD. So this appears to be very different from SIDD. Once again, I'm not saying that there can't be overlaps. There could be overlaps. It can all happen. So type 5 is a distinct metabolic entity with the basic features which I described. Deficiency of insulin, no insulin resistance, low body fat content, normal pancreas. It has a unique pathogenesis with probably a double hit nutritional problem. We need to understand the differentials of all other conditions. And of course, diagnostic algorithms is something which we should be working towards. So in summary, these are the conditions we should think of when we see a young person with diabetes, the differentials for type 1 and slowly evolving immune-mediated diabetes. We should also understand that there are several nutritional and social issues can impact the evolution of diabetes. I'd like to thank my funding agencies and also a number of my colleagues whom I've worked with. I wish I had all the photographs to put together, but some wonderful people who we have worked with over the years, and many I would like to acknowledge. Thank you for your patient listening.